Yeah, welcome, folks who've joined us for the FCI webinar today. We are from University Hospital Southampton. I'm the Chief Information Officer here, Adrian Byrne, not mentioned on the slide there, but also in the meeting those will be presenting today, Joe Watts, who's Deputy CIO and Head of Digital Programmes here, and Dr. Ashwin Pinto, who's a neurologist here and our CCIO, one of our CCIOs at UHS. We've been at digital for a long time here in terms of developing our electronic medical records, and the mobile presentation of it has come to the attention of people in the FCI, largely through a video that we did that we'll be showing something of later. We think it's a very innovative approach to demonstrating how to look at medical records in the hospital setting. Without further ado, I'm going to hand over to the first part of the presentation, which is from Joe Watts, who also is a Deputy Chief Information Officer here at UHS. So over to you, Joe.
Thanks, Aid. So give next slide, please, Ruta. So hi, everybody. As Aid says, we're here from University Hospital Southampton. Just a little bit about our hospital. So we're a large tertiary referral teaching hospital based on the south coast of England. We service a local population of about 1.9 million, but through our specialist services, we cover the whole of the south of England and probably a population of about 3 million. The specialist services that we provide include cardiac services and neurology, neurosciences, and we also have a children's hospital. Next slide, please. So just to sort of get straight into the problem, as Aid mentioned at the beginning, we've been working on developing an electronic patient record for many years. And one of the things that we find really interesting is working with clinical staff to look at how technology is used in practice in clinical care. And for many people that trained quite a long time ago, one of the things that they totally relied on was the chart at the end of the bed. And this has gone as we implement electronic patient records. So this has been a challenge that we've been trying to address. Next slide, please, Rita. And actually, it's getting more complex in terms of providing clinical care because there's so many other sources of information that need to be looked at in order to make decisions. So it's not just the end of the bed, it's about bringing together information from those other places that can sometimes mean that people feel almost overloaded with the information that they need to look at and struggling to perhaps bring it all together and then make decisions. Next slide, please. So just in terms of how this problem has developed, here at Southampton, we've had quite a long history of bringing in certain digital solutions. So right back in 2004, we implemented our electronic order communication system. It's called eQuest, and that meant that we got rid of all the forms used for electronic requesting of bloods, diagnostics, etc. And then in 2013, we implemented electronic prescribing. So all of the prescription forms disappeared. And then in 2016, we implemented electronic observations. So some of our staff said this was a real crunch point for them, that they felt at times they were starting to work from memory. And we quite often think about the benefits of electronic patient records being that all of the information is there in one place. We're getting rid of handwriting issues. We're making sure that we've got comprehensive notes, which is true, but there certainly is an access issue around being able to access that information and be able to absorb it. Next slide, please. So a little bit about our strategy here. I'm not going to say very much about this, but we're happy to answer questions at the end. Just wanted to point out that what we're doing at Southampton is very different from some other hospitals. So typically what you find is people invest in a single vendor EPR solution. There's a couple of large American suppliers, but also some UK suppliers that work in this market. And that's great because you have an integrated solution. But what we do at Southampton is that we bring different products together, combined with development in-house. But the thing that's really important for us is that we have a common clinical database with all our patient information, and we have full access to that information. And that's really allowed us to go away and do different things with that information and develop other applications. So I'm now going to hand over to Ashwin, and he's going to tell you the story of how we've done that in order to develop a mobile version of the EPR.
So next slide, please. So the ask was this. So we had clinicians, typically the person leading the ward round, who would start a ward around, at the patient bedside, as you'd expect. I mean, that's the standard way of going around patients, is starting at the patient bedside with other members of staff trying to retrieve all the data required for the person leading the ward round, typically a consultant, but not always, to make decisions on that patient. And the ask was, I need the data available, the correct data to make a decision on that patient. And that involves multiple systems that we need to be able to access. At its heart, it involves the electronic observations. As Joe says, that was the trigger for this in 2016 when we removed the vitals chart, the obs chart from the end of the bed. We needed a way to show the observations to the person leading the ward round at the end of the bed, not just back in the office where you could look it up on an electronic system, but at the end of the bed with the patient in front of you. So that was the thing that really triggered the change, the recognition that clinicians were trying to remember what they might have seen in the office before starting the ward round, but in fact the ward round starts with you in front of the patient and trying to make a decision. But then of course you need more than that to make a decision. To make sense of those vitals and obs, you need other information. You need, hopefully, the electronic prescription record, if you can get that, so you know what the patient's been prescribed and what's been administered to the patient. You need blood test results. You need, if possible, images. And then in an ideal world, you want the full stack of data available in our electronic patient record. You want the recent clinic letter or a recent discharge summary or all sorts of things that are available on our EDMS. And so the ask was to synthesize all this, bring it all together in a simple application that at the bedside, all of these various databases would be interrogated, bringing together a holistic set of data for the patient so that the clinician could make a decision at the bedside armed with all the correct information. And to our knowledge, very few big EPR vendors offer that single view of all the data systems that are available to make a decision for that patient. And so we set about trying to think, well, how can we put all of that together to make it much easier for clinicians? And the reason this got triggered more than anything else was the length of time spent by consultants doing ward rounds, particularly at weekends where they aren't supported by their junior team. So if you were supported by your junior team, you might have a junior doctor with a laptop open who'd been going between all the various databases and showing you the data. But if you're on your own, you're struggling with a laptop, you're logging in and out of systems to try and get that data, and it just wasn't efficient. And the key here was a read-only view. We weren't trying to write to the database or make electronic requests or change electronic prescriptions. That wasn't the ask. The ask was, can I have the data available to allow me to make a clinical decision on this patient? So next slide, please. So as a result, we're going to show you the slide. It's better than me talking through all the various functionalities. We'll show you a video with a lot of it. Here in the slide is a clinician with his nurse practitioner just saying how much of a difference this made. So at weekends particularly, clinicians were telling us they would spend hours on a ward round that would normally have been significantly less than that. And here's a small example. One clinician measured a 20-minute improvement in his time round. It's still going to take time to go around. Nobody's saying that it removes the idea of taking time at the bedside, but it just gives the clinician the data at the bedside to make those decisions. And I really think it's important that it's near patient. What we were seeing people doing, which was frustrating, was people were scribbling down on pieces of paper what the observations were or what the blood tests were, and then going around, and of course there's a risk of transcription errors and so on and so forth. That isn't a modern way of presenting data. We had to go mobile. The recognition was that we had to go mobile, and we had to take that data to be near the patient so that that's available at the time that decisions are being made. So as I said, read only, but importantly near patient, and available efficiently so that patients can move from one patient to another really quickly. And you'll see from the demonstration how that's achieved. So I think that's video time, isn't it, Rita? There we go. Oh, volume.
When you share the video, you have to make sure that you've shared your screen with audio in Teams.
We'll to pause it for a second, Rita, and we'll try and do that again with audio.
You might need to unmute as well.
It's because of the way you're sharing your screen. You might have to reshare it.
You didn't hear a sound?
No. So if you stop sharing and reshare again, Ada will talk you through it, because I don't know.
No, about that.
Sorry, everybody.
When you go to share at the top, at the point you select the window to share, at the very top of that menu, there's a switch that says include computer sound.
If you send me the link, I'll try and do it.
I'm sorry, I don't know why it doesn't work.
Let's see if I can do it. Oh, it's a private link. I can't search it on YouTube.
Oh, there you go. Joe shared it. Do you want me to share it from my end?
Yeah, why don't you do it, mate? Why don't you do it? Because if you know what yeah, that might be the easiest.
Okay. I've just clicked on it here. Okay. Screen. Share. Clear.
Which brings together
That working?
the absolute core information which clinical teams need to be able to see about inpatient patient care at the end of the bed.
As iPads became more prevalent across the organisation, a review was done, especially with the work that Matt and his team had done in the ICU wards. They've done a very similar product. So at that point, we chose to combine the two solutions into a comprehensive enterprise-wide model.
I think, yes, absolutely. And from as a clinical perspective, we really, it was kind of born out of experience we originally had in critical care, that as you take patient data electronic, it's increasingly easy to lock it away from the clinical teams at the bedside. It's very good for being able to review the data when sat in at a desk or in a clinic environment, but it can be quite hard to see very quickly the important information at the bedside. When trying to design the origins of DigiRounds, it was really about minimizing the number of tabs and bringing things together in a way that people were familiar with. We wanted no more than 6 tabs across the top, and so we had it started with a patient summary, and each tab has an icon to assist the teams in knowing exactly what that tab is. And the little brief describer, so the summary, which brings together in a format again that clinicians are used to, the patient history in a nutshell, going down the classical route of history, presenting complaint, past medical history in the sequence everyone's used to, but then also putting in quick access in that tab to correspondence and previous documents on the patient's history. The next tab along is that of the OBS chart. And this is an OBS chart which is again very much based on what historically paper charts looked like, but utilizing the power of it being completely up to date and using color to highlight new scores and bringing in experience we had from critical care, bringing in gases, blood gas results and elements like that. And again, the importance of making it historically familiar is that clinicians could look at this and would instantly feel familiar and able to quickly assess whether the patient was sick or not. And then we had the results, and this again brings together the results in a tabular format designed for touch, so it's absolutely beautiful. You can scroll with touch left and right to view back in time, but the sequence of the lab results being formatted in the classical format that clinicians have always been used to, and that I spent many years as a junior writing in the back of patients' notes in tabular form. But again, bringing in the very latest microbiology results, and we're on the verge of releasing an update which will allow teams to actually acknowledge the results within it as well. So we've got access to all results there. And this can mean that if a result becomes available while you're on a ward round, you can actually see it there and then, rather than only seeing what had been available earlier on in the day. The results tab, then we have the packs, so a direct format to be able to look at X-rays and CT scans, which is incredibly useful to be able to see instantly at the end of the bed, but also wonderfully powerful to be able to show the patients or to be able to show relatives, and really allows you to explain what's going on. And we have notes, which in critical care, where we are fully electronic, shows the notes, and this is already being up and sort of designed behind the scenes for as the trust starts to roll out a trust-wide e-noting solution, so that teams will be able to read a continuous stream of notes at the end of the bed. So across the top, it has a simple set of tabs doing the key elements, and not having too many tabs, because from our experience, when you had too many, people would skip tabs and would only cherry pick a few. So the important was having very few tabs and having them in the order which the teams would normally look at, or clinicians would normally look at when reviewing a patient. And then you have the patient list down the left, so that you can simply skip from one patient to the next and very quickly go down that, and that can either be in ward format, of actually just as you move around on a ward round, you can simply go to the next patient, or it can be in team format, so you can go down and see the patients, sorry, the clinicians' patients actually in their order. So very simple to use. And if you step back from it, it really starts with essentially one button which brings up all the wards in the trust. So you start with all the wards, you can click on the ward, and it takes you straight into the patients on that ward. So it is very quick to navigate between wards and to find patients as you need to when you're on the shop floor, walking around, trying to see patients quickly, or in particular, if you're called to a sick patient. So there is no desperately trying to find a hospital number, desperately trying to find a computer. You can turn up with an iPad, click on that ward, quickly identify the patient tile, click on that, and you're straight into the summary, the OBS, the results, and in a position of making rapid decisions about that patient.
So just to add on to what Matt was just saying there, as part of the architecture of the application, we started introducing the Care Connect APIs, which is an industry NHS requirement for all organisations. So in the version of DigiRounds now, we're actually using the observation resource for results, and we're using the patient resource for demographics. This is a strategy for NHS X to use, and we've implemented that across the application as well.
If the paper is actually at the end of the bed and you can pick it up, you can see data straight away. And as Matt so eloquently describes, we were beginning to put data into good databases, with all the advantages that accrues from that, but with the unfortunately the side effects of removing data from the bedside, from a chart at the end of the bed. So we touched on the integration, but to my knowledge, we're one of the few trusts that have been able to integrate all of this in a mobile application. We've gone through the systems, just one that hasn't been mentioned. So amongst the things we can do, we have a patient overview, we have an OBS chart, a results section. We can call up the patients, CT, MRI, or radiographs on the PACS system, on our own PACS system, with excellent quality, probably rivaling any laptops that people carry around to try and look at scans. And then one thing we haven't mentioned is the integration across so-called e-prescribing. And as in many trusts, e-prescribing is complex. And we have, for example, patients on ICU on a different e-prescribing system from our main e-prescribing system. And so we then have to find a way of making sure that when you're, as a physician, particularly doing a ward round, you're able to not only review all those other things, but make sure that you've seen the relevant medication that was prescribed in ICU if it applies to that patient, and also what has now currently been prescribed. And that bird's eye overview of a patient has moved the speed of ward rounds from a time when clinicians would be saying that an average ward round of 20 patients could rapidly spiral into many hours, with frustration with laptops, losing Wi-Fi signal, not being able to access all the multiple different databases to get the data out to show the clinicians that they were making the right decision at the end of the bed. Suddenly you have an iPad, a mobile solution. The person leading the ward round typically uses the iPad. There is still a need for us to carry other devices around because we need to be able to write to the database, request tests, change medication. But just that ability to integrate data, to give an oversight, to allow clinicians to be much more efficient, to make the decisions quickly, with backup from the rest of the team. Because, as I said, it's not only a single device solution across the whole trust. We're not just using iPads for all inpatient management, but they've become a key component of how we review patients by integrating data across many different systems. We believe that's the future of how you make clinicians more efficient at the bedside, by giving them back the power they used to have when they had everything at the end of the bed. But of course, we all know that it wasn't always at the end of the bed when clinicians were doing ward rounds. So we've got the power of databases sitting in the back with the sophistication of integration and overview of data on a tablet device, which just transforms the way that clinicians can see and review patients.
We do look at trying to standardize the formats of viewing data across trusts. One of the hardest things when you start in a new trust, and there's a lot of movement of junior doctors between trusts and also of nursing staff, is suddenly learning, having to relearn how to use the systems, but in particular how to simply view patient information and to be able to work out whether a patient is sick or not. It's always reminiscent to me of how when we start out taking bloods in the different hospitals, all the different bottles seem to be different colours in different trusts, and then they were all sort of standardised to a set of colours, which meant that when you moved to a new trust, you at least knew what to take a full blood count in. Well, in the same way, we need to be standardising the views which clinicians are used to seeing, so that when you turn up in a trust, you could potentially pick up an iPad, a tablet, or whatever, and be able to very rapidly see if a patient is sick in a familiar way that is reminiscent of the previous trusts. And something like DigiRounds, with being a framework, as Naresh said, and moving between trusts, as Ashwin has said, could really be an incredibly powerful way of harnessing all the data in all the different databases, but at least providing it in a uniform, unified, focused way for clinicians to be able to see at the end of the bed in whatever trust they are working in. DigiRounds has been incredibly important to our ability to manage patients during this difficult time in so many different ways. So with the ICUs going into full PPE, it's made using computers in there much harder, and actually simply being able to look at tablets, which are easier to clean and easier to move around with, has been really important. But also being able to remotely view. So, and that's not necessarily off the trust. In critical care, because the unit may be in full PPE, often the ward rounds are done in a room outside of the actual unit, away from the patient. And being able to have all the members of the ward round using iPads, being able to view data, being able to present, so the junior doctor may be presenting from what they've written, or as it were, typed in the system, they can view that. What are you able to view the OBS, and the whole multidisciplinary team can use the iPads to view what's going on with the patients. And then also with the numbers of patients scaling right up, and clinicians looking after more patients, sicker patients, and also patients with conditions they're not familiar with. So our cardiac unit has really did an incredible job looking after a lot of general ICU cases during this. And I actually had one of the cardiac intensive care consultants contacting me to to really just to say how important DigiRounds had been for them to be able to have a quick overview of the patients they were looking at, but also when on call and when off site, the ability to quickly flick through and see the core patient information for great scaling up numbers of patients was incredibly important. And Nilesh's team has done an incredible job with this and bringing it together. And the ability to scale up the number of patients. So we were able to really at the drop of the hat add extra departments into DigiRounds as they were as other areas of the hospital were potentially used as an intensive care environment. It was incredibly flexible, but allowed the clinical teams who were responsible for looking after the patients to still be able to see the key information on all of those patients quickly and fast and in a format they were familiar with. So it has really, really helped during this incredible time of huge numbers of changes of patients that we've had to deal with, and the different circumstances we've been working in.
So from a technical point of view, obviously DigiRounds, it works on an iPad, and it now allows us to support the BOID option. So clinicians are able to buy their own personal iPads. We can secure them for them using our secure iPad solutions, and then allow them to use DigiRounds from home. So we're no longer restricted to trust-based devices. As long as the device can be secured using our technology, any iPad can now be used to use DigiRounds, and a lot of clinicians have done that to allow them to work from home.
And then finally, just to really to highlight both points really from both Nilesh and Matt. So I think if we'd gone into COVID-19 2 or 3 years ago when we were doing a lot of this work, but we hadn't got the mature products out, we would have struggled. We really would have struggled at times, because we'd have probably reverted back to paper charts in places, because that is one way of getting around some of the problems with data being difficult to access. We would have had difficulty with teams who've had to have patients all over the hospital, because you have isolation wards and patients who are COVID negative in other places and so on. So we needed an ability to surface the list of patients that clinician needed to see that day, and easily make it available so that you could get round your patients and efficiently discharging patients where you could, just making critical decisions fast. And what we found, and we knew this from last summer, thankfully before all this hit, when we were looking at our efficiency, we could show that hours were being saved off ward rounds by just the use of the lead for the ward round being able to access all the relevant information on an iPad. And realistically, had we had the problems that we were, the slowness of using the previous systems, that they were fine, but that they were, as they are on laptops, they can be a bit slow and a bit difficult to access as laptops struggle to pick up Wi-Fi signals on. I think we'd have found it much harder.
Okay, I've stopped sharing that so you can take control back, Rita.
So next slide, please, Rita, when you're ready. So as the slide says here, things don't stand still. That was, I think that video from memory was made in 2020, towards the end of 2020, or maybe early 2021. But we've moved on from that, because what we need to do is continually improve the product as we get feedback from clinicians, and make it a more effective product. So we talked about the fact that at its heart, to start with, it was a read-only view of the database, but there were some simple requests, and one of them was that if I could just acknowledge results on the device, that would save me a little bit of time later on in the ward round. And again, doing things at the bedside near the patient is more efficient than having to remember to go and do it somewhere else. We're very proud of our results acknowledgement system. For those who don't know, in Southampton, built into our eQuest system. Essentially, we are able to show that we acknowledge over 95% of hematology, biochemistry, and even cellular pathology and radiology is very good figures, because we surface the results electronically and people can sign them off within our full EPR. What we want to do is, where possible for certain test results, allow sign off inside our EPR. So if we move forward, we'll go through some of the things. Next slide, please, Rita. We'll go through some of the things that we've been able to do. So pathology here on the right hand side, top right panel, we can look at pathology results and then acknowledge them, and that saves the junior doctor time. So we maintain the importance of actually actively acknowledging a result with the audit trail to follow, but actually do that at the bedside. So that is writing to the database. That's a full example. It's the first example we've done of writing to the database. The second thing that we did, again, as a request from the consultants and other people, was that let's surface more data. Let's get more data out. So let's get some of the allergy data that is stored away in JAC and elsewhere, and show that in a nice, easy interface so you can see it quickly. We made sure bottom, so that's the top left panel, bottom left panel, we have run a full EDMS. Not all of those documents were immediately available. Now what we've done is make every document available that's on our EDMS through an API. We can make that available through a mobile solution. That's fantastic. It means you don't have to go back to a PC or a laptop to just look up a letter that you think might be important when you're looking at the patient. Perhaps they've been seen in another specialty recently in clinic and you just want to look at some handwritten notes that have been scanned on into our EDMS or something of that sort. Again, we can now give access to that at the bedside. That's the bottom left panel. And on the right panel, to start with, the product allowed the critical results that you'd want, the basic chemistry and hematology and so forth. But actually, of course, we want to know more than that. We want to know immunology and more complex results. And that now is all available coming back from eQuest. And even more powerfully is the ability to see what tests have been requested. So no more do you stay at the end of the bedside, have we done this test on this patient? The mobile app will tell you whether you've done that test on the patient. And that, should it in theory, and I'm sure has, led to reduction in duplicate requests because somebody's not quite sure, they put in a request there and then because they're a bit uncertain, and actually it was unnecessary because the request had already been made, but it's just a time taken for the result to come back into the system. So those are the main developments that we've developed, on those 4 panels. The other features listed in the middle there. So we can now look at patients who aren't admitted to hospital because, of course, increasingly with virtual wards and so on, we want the ability to have patients who are not on our eCamis system as being in hospital, and it allows us to see what the trust acuity is like as well through a dashboard of the scores of patients with who might be deteriorating and so forth. So those are the key developments from release 5 as shown there. Next slide, please, Ruta. And then what else? What's to come? Well, nothing stands still. iOS changes every September, October time, so we need to upgrade the support. We're on much firmer footing with that now. We're beginning to work to put emergency department patients in. It's complex, that area, because emergency department patients, certainly in our trust, don't sit within our eCamis system. They're not admitted onto eCamis. They're admitted onto Symphony, and their ED management is through Symphony. We'd like, and we will, move to inpatient noting. We've got nursing records going live in my own care group, neurosciences, just now. Soon to follow will be medical noting, and that should be both accessible to review through an iPad. That we've designed it with that in mind, but importantly, probably with speech recognition. We're fairly confident in this. You'll be able to make a note with an iPad by going into the form to complete and then being able to just speak into the iPad, and speech recognition will help the data entry because iPads are not great for typing on, obviously. We'll make some changes to the way that we show the results. We'll hopefully be able to pull through primary care results because we have access through that through our community and health information exchange. We'll have more document summaries available, and we'll just make it a bit easier to use. And that's release 6 coming hopefully over the next few months. Now, next slide, please. And then this shows you a little bit about what release 6 will do. So again, I won't labour the point, but there's a variety of different things there that we're adding in: the inpatient noting, the ability to look at patients in the emergency department, and a little bit more about how patients on ICU can be reviewed. Just to emphasise, this one application allows you to review patients on an ICU as well as on a ward, and that's a huge power. You don't have to move into another application just because different systems are used in ICU than elsewhere. It's one application throughout all of the trust. Next slide, please. And then again, a little bit more about the emergency department work that we're doing, which we're just explain again why we're in this position. We're in this position because those patients don't sit within our main eCamis, as is often the case with ED systems. So we're having to build an interface that allows us to surface that data in a way that's useful. And again, that's been a real request from the teams who go down to ED to see patients, but also from ED themselves, who want a better way of reviewing their patients rather than using the various Symphony systems and other systems that they're having to get the data out of. So we go forward to the next slide, please. We talked through some of this inpatient noting. We're not yet in the stage where we're doing electronic inpatient noting for patients on the main wards, but of course we are fully electronic with our CIS of MetaVision in ICUs, and so at least with those patients it's an easy access to view all of the notes for that patient. But soon we'll have the ability to create inpatient records from admission onwards and continuity records using the iPad, and we designed the application with an iPad in mind. So of course you can use a laptop that will be carried around, or computer on wheels or whatever, but actually we wanted the principle to be that you could carry an iPad around and that will be your primary data entry device, and we hope that speech recognition will make that smoother for clinicians rather than having to type somewhat awkwardly on an iPad screen. And as it says there, the inpatient module checks whether the patient's currently admitted. The patients are shown in the team, consultant views been discharged, and will not launch the module. So that it'll be an efficient way, we think, for allowing us to enter data for patients on ward rounds as we move to electronic inpatient noting for doctors as well as nurses. Next slide, please. And then this is just a little bit to show how we've improved some of the functionality within complex data sets, like on a ward round, you may want to drill down into, as it says here, the precise white cell breakdown or the red cell indices such as MCV and so forth, and all of that we've now made visible within the application, but hidden away so you don't have information overload. There'll be certain patients it's just not relevant for, others where you want to drill down and get more detailed information. That's just a press away from getting more detailed information. And we've broken down a little bit better the division between biochemistry, hematology, and other lab services. Next slide, please. And then finally, just to make it easier to go through different results, 30 days at the time seemed like a very good amount of data to be pulling back now, as we all suffer throughout the NHS with delayed discharges. In fact, we're not allowed to call them delayed discharges. Whatever we call them now, patients are in hospital for longer than 30 days. We can now pull back data if necessary for as much as 60 days, and that's been helpful for some teams. And then well, maybe not final slide, but next slide, please. And then again, some of the results that weren't available before, we may be able to get those through another system by being able to integrate with our various other databases like the Community and Health Information Exchange to be able to pull through results from elsewhere, which is incredibly valuable for clinicians rather than going into separate databases again. And then next slide. Yeah, we're repeating ourselves here again, and as we said, we can visualize now lots more document types by our APIs drilling down into EDMS, making that much easier. In fact, probably it's an easier way than using even a PC is to use the APIs that were provided by Highland to allow us to access those documents within a mobile viewer. Bluntly better than Highland's own mobile viewer, if I'm being honest. So we now use their API to show it within our own viewer. And next slide, please. And then we're moving towards using encryption so that it's an HTTPS URL rather than an unencrypted thing to meet modern proper security standards. And then final slide, but we're talking a little bit about, I think, business. So next slide, please, Ruta. I think the next slide is about business continuity applications. So of course we need to plan for, as we had actually a few years back when we had a major power outage, how do we make sure that data is available? And we've thought through that, and Nilesh and Toby Cave and others who are key in this project have looked at ways of making that data available, even in the event of fairly catastrophic system failures. But we still would be able to make that available at the end of the bed. Sorry, at the end with people being able to use iPads and so on. If you ask, well, how they're going to work, well, of course, hopefully you might be able to have access to Wi-Fi, or indeed you might be able to use your 4G or 5G enabled devices to be able to access data. So we've thought about ways of making this data available, even in situations where systems have gone down, or indeed in more catastrophic cases where there's been power failures and so forth. So that's an important principle, that as you move away from paper to electronic, you have to think what happens in those situations where you need to be able to access data even though various critical systems are down, through the usual forms of access. Next slide, please. Okay, and then a quote from Robert Wachter, who those will know, was commissioned to write a report a few years back, which led to various changes. And it says here, unhappy physicians a hospital recruiting docs added no EMR to its ad, the demise of radiology rounds, and the lack of user-centered design that makes docs for their paper charts. So we use paper because we're really familiar with it. It takes seconds to flick through, and we get all the data we need to make a decision. We hope that with eDocs, with DigiRounds, we've moved a long way towards making that a lot better. So here we go. Don't know. This is from a physician from our recent class survey. I think this is actually just before the pandemic hit, and I would say that we've made much more improvements as shown in earlier slides. You know, I think our clinicians would now say that they're not limited at the bedside with the data they can access efficiently on a mobile device. Whereas if you went back 4 or 5 years as we started this project off, we knew we had some limitations there. So that's a nice positive review as shown on the slide. I won't read it out. So thanks everybody. That's I think the end of our presentation. We've got a few minutes for questions.
Yep, thanks, Ashwin. Jonathan.
Thank you. A bit about the culture and the environment, please. This sounds like very rapid development. You've got 5 and 6 lined up there already. What's the belief of other consultants that this sort of thing can be changed? And of course, this relates to the general argument about best of breed or big American system or whatever it is. What's it like culturally in the development cycle? And what's it like in the procurement? And how many people do you have to convince to get the next set of developments?
Okay, I'll pick up some of that, and then perhaps Aid will pick up others. So if you look at the thing that I think was key to this, it was, as you'll be delighted to hear, Jonathan, clinician-led. So it was led by clinicians saying we need ability to review patients at the bedside more efficiently than we are now. And of course, as you know, Jonathan, we're in the lucky position of being able to write our own software. So it was all developed in-house. So in that sense, Aid will talk about developers and software procurement and so on. But we started from a strong position of open access to our databases, so we knew we could get the data out. The question is, how could you best design it? And I want to pay huge tribute to the person on the video, Matt Cordingley, who really understands UI, really understands it from the clinician's viewpoint, and drove this forward with a good steering group, Jonathan, including good representation from surgeons, from physicians, from ICU physicians, all the things you'd expect, got clinicians together with the right technical people to make rapid changes. And it was, you're right, it was very rapid. It was done not perhaps on a weekly cycle, but certainly on a monthly cycle. We were making rapid changes. That's why we're on revision 5 or revision 6. It's a much more mature product now, but early on it was quite rapid changes to get a really good mature product out there for clinicians. Hey, do you want to pick up something about the technical side and the from the informatics side angle on things?
Well, yeah, I mean, I was going to ask Joe to comment on it, but I will say that it's an interesting dynamic when you're looking at the way that we implement things versus the way that you implement things under a large contract with a supplier. I was having a conversation with another CIO in Hampshire the other week. One of the challenges that we have is the same as they have, which is we might develop something and a few of our users might love it, but we're not contractually bound to roll it out. And as an organization, we're traditionally not very good at making people do things, i.e. saying, this is the way we do things around here. So what is it? You know, you find that you have to make things that are so good that people, you know, want to flock to them actually, and that's great, except it does leave you with a hill to climb and also potentially quite patchy implementation. This is used everywhere. I think, you know, if you walked onto any of our wards, you see DigiRounds being used, but there's undoubtedly a challenge with some other things that we have which are used in a more patchy way. And the other CIO in Hampshire, as I say, remarked to me, well, if we just signed a contract with X vendor, at least everyone would be bound to, because it'd be in the contract that they have to use it, and that's the easiest way I've got to roll anything out. And unfortunately, getting beaten by a big stick is sometimes the way to get things done, and it just isn't the way we've done things around here. So I think it is culturally different. Developers and development, obviously it's getting really difficult to recruit any kind of staff, and I know, Joe, you suffer a lot with that at the moment, don't you?
Yeah,
so pick up on that. Yeah.
Yeah, so I mean, I think one of the reasons why developers like working here is they like the contact with the clinical teams. They like that working with the clinical teams. They get a lot of satisfaction, particularly working in an agile environment, having the conversation, going away, developing something and having that rapid turnaround in terms of response and then the ability to trial things. I also think that we benefit from the fact that Ashwin and Mike and Sarah, who is our chief digital nurse, they chair the development group, so they kind of receive the requests for development which come right the way from across the trust, and they're really involved with the team in terms of making decisions about prioritization of development. I think that we have a core of developers that really want to stay with us and keep doing this because, as I said, that there's that they like this way of working. But there is an issue, I think, in terms of growing the team and that maintenance burden and going forward, just in terms of keeping, attracting people to come and not only work here and train them up, but keeping them encouraged to stay here when there's so many other opportunities elsewhere. And I think I just want to mention a little bit about the rollout process. So once the application was developed, we worked really closely with the chief operating officer at the time to identify the teams that we deployed the DigiRounds iPads to. And there was a discussion at the beginning about whether we should issue them to people individually or we should issue them to teams. And we started off issuing the teams. At the time we were a little bit financially constrained. We could only afford a certain amount of iPads. Over time we've managed to roll out a lot more, but it was quite interesting as once you issued a DigiRounds iPad to a team, particularly where the users realized very quickly it was incredibly useful. We got a lot of requests really quickly saying people wanted one for their own use, particularly for consultants who were on call, who really enjoyed the fact that they could be woken in the middle of the night, be talking to a junior and see for themselves exactly what was going on and have much better quality conversations with the team and help support that patient care aspect. And some of the seniors have said that they have to come on site less often because they've got access to this information at home and they can make better decisions and support their teams using this software.
Okay, me again. So on usability, firstly, what's this written in? Is it iOS WebKit or is it some browser server system?
I'll tell you a little bit about my knowledge, and then Joe and others can. So my understanding is this: might interest you, John. We have a single physiological database, really, as long as you're outside of ED. We've talked about why that's the case. So as soon as you're admitted to hospital, all the OBS go onto a system called SafeTrack, which is actually technically the same database as we use in ICU, and in fact the same database that we use in cardiac theatres. So if you're in and out of cardiac theatres, you're on one physiological database during your entire time in the hospital, which is interesting because there aren't many hospitals where that's true. So you have this lovely physiological database, and the OBS chart bit that you've shown is actually I think a SQL query, isn't it, Aid or Joe will know? It's some form of query that we call back, and it's created on the fly, and it's a PDF. So you're right, it's written in WebKit. It's a WebKit compliant thing. And the nice thing is, John, and it's such a useful view for a patient that we made it available in our main EPR so that you could also access it on a PC or a laptop. It was that good a view that actually we had enough people say, why do I only have to look at it on an iPad? Why can't I also access the same? Now, it looks slightly different and so on as you'd expect, but fundamentally, the view is such a useful overview for an inpatient that it's become also widely used as a tab within our main EPR, but has slightly different functionality, but not functionality, but slightly different use case. But fundamentally, it's a useful way of surfacing inpatient data that we didn't actually replicate on our main EPR. On our main EPR, it was a series of going through a results tab, going into the OBS tabs, and it was just a little bit less efficient than it is as I've just shown on the iPad, and therefore in that unified view inside a web browser on our main EPR. So WebKit, yeah.
So yeah, I mean, it's worth noting then that I mean, that was an interesting development, wasn't it? That we thought it's just an iPad, and why can't we have this on the desktops? And all right then, so we'll go away and do a bit more work. There's a lot more going on here than just the WebKit stuff, obviously. We use InterSystems Ensemble Health Share as our integration engine. So that's the thing that's driving the APIs. And as you heard Ashwin say in the talk about us mining the data directly out of the EDMS so that people are not having to go and load another client. We're loading the documents directly out of the electronic document management store into this app. So there's quite a bit going on in terms of integration. We also use Oracle in the background, and one of the screens in there that we showed on the clinical noting was of our clinical noting app, which is actually built in Oracle Application Express. So there's a little bit of that you will see in there as well as you migrate or navigate around. But the real interesting thing for me about putting it on that desktop view was that we've now moved on to developing a business continuity application for the organization in this space, which means that if any of our areas are affected by something like a major outage of, for example, the network, we've broken the hospital down into sections, and certain machines, business continuity machines in the organization, are now holding all of the data in DigiRounds in encrypted stores. So we can then initiate a program with the hospital control room to unlock those encrypted stores in the event of any major system outage. So DigiRounds has inadvertently given us a fantastic business continuity solution, which helps with our compliance for HIMSS level 5, which we're obviously hoping to achieve by March 25.
Yeah, it's interesting. It wasn't the technicality, the technical aspects that I was going to ask about. But yesterday I was talking to a new clinical student and discussing why small screens force you to produce lean interfaces instead of the horrible spreadsheet that he'd seen on the native EPR. You can only do it that way. So actually taking the small screen back to a bigger screen, yeah, is going to give you a bigger element. But the reason I asked about the WebKit was, can you auto record the user actions for developing the later versions? If you're doing this, you're likely to do this next.
That's a good point, actually, and that's the UI bit that I'd love to get more into. That I'm sure we could. I'm not as good on the tech stuff as Joe and Aid. They might, but yeah, I can't see why we couldn't. And actually, we should be doing that. We should be looking to say, well, what's predictive? How are you using this application, and can we make it even more efficient for you to use this application? So I knew that you could do that on a Apple device or another device as well, but I didn't know. We haven't yet done that bit of work. I know Matt Cordingley would be really keen to do that. And in fact, actually, I'm sure Aid and Joe know this. We've been approached by Apple because I think they've worked out we bought a lot of iPads, and they've asked us what they can do to help us with some of the work that we're doing on this, because it is I think it is quite groundbreaking in some areas. There are very few hospitals that are using iPads quite like this, I would have thought.
Yeah. So if you look at some of the the well-known EPRs, they tend to be implemented with a Citrix kind of environment, don't they, which will run on iPad, but of course what we have the benefit here of being able to deploy native iOS and run this application on it, which gives us all kinds of benefits. For example, in terms of remote use, using our hospital VPN, you can just unlock the thing at home with your fingerprint and you're straight into the app with a live view of the record. That has massively helped hospital doctors working on call, not having to get out of bed and log into a PC and a VPN and all that in the middle of the night. I'm sure you can imagine. We've heard about EPR implementations where, like you said, Jonathan, where you've got a massive spreadsheet view of the record. It's too much information in one go, isn't it? We've heard about. I visited one of the US hospitals a few years ago, and they had bought in a clinical portal application to sit above their electronic medical record to distill that view into a more digestible clinical content for the doctors. And some of those big EPR vendors are now even recommending that you can't run their application on any less than either a huge monitor or dual monitors, because they insist, I mean, they've got their own views on governance, obviously, but they insist that they throw all the information at you, so it's no longer their problem. Well, really, that is not suitable in the kind of environments we're talking about, is it? So, you know, that this is why it's such important work. And I think you know, from my perspective, the DigiRounds thing that we've done here has really hit kind of a sweet spot in terms of that usability. But we are not user interface experts, and we do recognise that, and we have talked about employing a UI UX expert, haven't we, Joe? I don't know how we're getting on with that thinking.
Yeah, we have, and also we've been talking to the University of Southampton about working with them, because they've got some people that have done some research in this area. But you're right, Aid, we're not user interface experts, and obviously the user interface for DigiRounds was completely designed by Matt Cordingley, based on that kind of really trying to help people look at information in the way that they used to look at information when it was on paper, because he said that he could absolutely correlate that with the ability to quickly assimilate the information and make decisions, because it was so familiar. Now, we still don't know whether that stands as we sort of get, you know, mature the product, but also we've got a whole load of doctors coming through who may not have worked in that way in the past, so there's probably some learning there in terms of how this might evolve over the future. But I think that information overload is something that we're really conscious of, you know, giving people access to the right information that they need at the right time, but making the links, as Ashwin said, about what you need to see alongside something else in order to make a decision, rather than throwing everything, and including the kitchen sink, at people and saying, there you go, that's everything we know about the patient.
Yeah, so I put a note in that the select committee as just looking at digitization of the NHS. We're going to be putting evidence in from the faculty. One of the issues there has to be progress and barriers to progress. And I find it quite stunning that there isn't what a new nurse, what a new F1 should expect in front of them. That's not a system statement, it's a functionality statement, because then we could all start assuming that and then building up. And at the moment when we're educating, you don't know how to start, because you don't know the minimum. And it's also not, it's the opposite of global digital exemplar. That's what's the highest has anybody done. What we're looking for is the minimum that should be everywhere.
Yeah, agree. We're almost out of time, aren't we? I think.
Just a comment in the chat, but it's not a question.
Yeah, I can see that.
Hi, Kay.
Hi, yeah, I just wanted to say that it's a really great story. It's nice to hear, I think. And like, how many times have you heard a nurse at a computer saying, like, what is this system doing? You know, if I was going to design it, would do this and that. And it's just, so it's really nice to actually, you know, see a system that had proper input from clinicians. Yeah, and I work for one of the big bad ones. I'm from Cerner, so.
Well, you know, as Matt Cordingley says in the video, and he is the inspiration behind that, the whole thing, in terms of, you know, we were kicking around trying to do a mobile presentation of the EPR for about 3 years, actually, and never getting it right. Yeah. And then Matt came up, because we'd done the work in critical care, and said, look, this is what you want to do. And actually, the simplicity of it is that, why don't you just focus on what doctors have trained on? You know, that user interface at the end of the bed has been honed over 100 years or something. And that's exactly what they've done. They've just copied that. You know, it's simple, if you like, except I'm sure you'll understand that some of those things, like, for example, the way that those results scroll backwards and forwards on the touch user interface, they spent months doing that, trying to decide whether they were going to show the latest first and then scroll left, or whether they were going to show the last and then scroll right. Eventually, they decided they'd have to do it logically. You want to wipe from right to left as you're reading. So they show the latest there and then go backwards, and that took a lot of time. So just thinking about that one aspect as an example.
Yeah, imagine a lot of work goes in.
Okay.
Good. So we're about up on time, aren't we, Rita?
Yeah, no, and I've got to get to another talk. So.
Yep.
So good. So I think we'll sign off then and say thanks for coming along. Hopefully the video will get uploaded for others to watch, and hopefully also you'll be able to do a bit of editing to take out that little bit where we couldn't get the video to work. That would be fantastic.
My apologies.
We'll keep
That's
it
all right.
realistic. Just great. Thank you very much. We'll do everything we can to publicise this, and I say I'll connect it up to the select committee. Thanks everybody.
Thanks
great.
so much. Thank you,
Thank you.
everybody.
Bye-bye.
Thank you for joining. Thank you.